So this concludes our first scientific session, and we will move to our next sponsored talk, which is on realize the potential of GLP-1 with the once weekly semaglutide. And for that reason, I will request our chairpersons first to join us on the stage. I will request Professor Dr. Najmul Islam, who is a professor of endocrinology at Aga Khan University Hospital, to kindly join us on the stage. And we are expecting Professor Muhammad Umar, who is a hepatologist. Okay, I think he is not here, so I will request Dr. Umar, who is a consultant endocrinologist at Shifa International Hospital, to join us on the stage as a chairperson. Now, can I kindly request Dr. Reyaz Malik, who is a professor of medicine at Weill Cornell Medicine, Qatar. He's an organizational official for the Human Research Protection Program, to kindly join us for his talk. Thank you.
Thank you. Assalamu alaikum, everybody. So it's a pleasure to be here in Pakistan again. And yes, my slides are here. Okay, so the focus of my talk is around GLP-1 therapy, or actually GLP-1 plus therapy in the management of type 2 diabetes. These are my speaker's disclosures. This particular talk is sponsored by Novo Nordisk. I have received a large honorarium from Novo Nordisk to do this talk alongside 2-3 other talks, but all of my money has gone to Gaza, to Palestine. So, I take you back almost 100 years when Elliot Joslin from Boston said, from an excess of fat, diabetes begins, and from an excess of fat, diabetic patients die. It has taken us 100 years to realize what this man was saying, because actually, we've conveniently ignored the importance of being overweight and the effect it has on type 2 diabetes for 100 years. And what we have had is what I call, or the British call, an elephant in the room, which is that I know there's a problem, Dr. Said knows there's a problem, Dr. Abdul Jabbar knows there's a problem, but we don't want to discuss it because we have no real answer, okay? And what was the problem? Well, the elephant in the room was that if you look, all the medications that we have available for people with type 2 diabetes are sulfonylureas, meglitinides, TZDs, and particularly insulin. What does it do? It increases weight. So if fat is the underlying problem, why are we giving medications that are going to increase weight? And that's where we are now in a new era. Okay, and I put up this quote from Charles Dickens from A Tale of Two Cities. In 1859, he said, it was the best of times, it was the worst of times, it was the age of wisdom, it was the age of foolishness. And I believe right now, honestly, we are in the best of times. But we could also be in the worst of times if we don't look at the data and say, you know, this is the way I need to manage my patients with type 2 diabetes. And so I take you through history where in 1922, 100 years ago, we had insulin, which of course was life-saving in type 1 diabetes. But I do not believe this is and should be the major drug that is used in type 2 diabetes, apart from a small subgroup of patients who are insulin deficient. And any company that tells you that they should be putting more people on insulin is wrong. We then have sulfonylureas and biguanides, And then we have actually a period of stagnation where actually the older diabetologists probably had it easy because there was only like 1 or 2 drugs. And, it's not very difficult. But what we now have is a profusion of new therapies, in particular, and I put it in bold, the GLP-1 agonists, where you see this is actually 2005. That's the first of the GLP-1 agonists. We then have, in 2014, almost 10 years ago, the first long-acting GLP-1 agonists. And now we have a whole bunch of new therapies, which are GLP-1, GIP agonists, oral GLP-1s, and the triple agonist. So are these useful? I believe so, because we are now actually creating a new speciality. It is no longer bariatric surgery. It is what I call bariatric medicine. And as physicians, as endocrinologists, we are actually optimally placed to take this on board because it will have a fundamental effect in the management of people with type 2 diabetes. And what we have witnessed over the last 20 years is a true, what I call revolution, in terms of the initial approval, FDA approval in 2005 of short-acting exenatide. And this is now followed on to currently actually a lot more, but semaglutide long-acting, which I believe is a very important and efficacious drug for the management of type 2 diabetes. Does it work? Yes. And if you look at all the data from all the big trials, bottom line is, if you look at the dark blue here and you compare it to all the other GLP-1 agonists, whether they're liraglutide, dulaglutide, exenatide ER, semaglutide is the most efficacious, achieving HbA1c reductions of anything around 1.5%. But the other thing that these GLP-1 receptor agonists do is the complete opposite of what insulin does, of what sulfonylureas do, of what TZDs do, which is they help you to reduce weight. And that weight loss in the 1 milligram dose is around 5 to 6 kilograms in some patients. How does it achieve this? Well, actually, primarily, and if you ask your patients, they will tell you this, it is like a switch. And they, honestly, patients come to me and say, what's happened? It says magic. And I'm like, okay, I'll take credit for that. But they really tell you, I don't feel like eating anymore. I look at some food and it's like, I can't finish the plate. I no longer order my pizza at midnight. And that is the primary way or underlying mechanism by which GLP-1 therapy reduces weight. But actually, beyond reducing glucose and reducing body weight, we now know GLP-1 therapy has important effects in terms of reducing inflammation, improving the lipid profile to an extent, reducing blood pressure. And I can tell you, the newer agents, the triple agonists, are dropping blood pressure more than blood pressure lowering drugs. So that is going to be a huge plus in our patients with diabetes. And there have been experimental data showing there is an anti-atherosclerotic effect alongside improvements in terms of heart failure. So overall, there is a compelling argument that GLP-1 therapy will address many of the abnormalities that you see in your type 2 diabetic patients. So what is the evidence that these drugs work? Well, in 2019, there was a systematic review that looked at the effect of all the GLP-1s, not just semaglutide, but all of the GLP-1s, and assessed whether it improved cardiovascular outcomes. And what did it show? Well, across the board, there was a benefit in terms of MACE outcomes. So this was around 12 to 15%. Okay? But nevertheless, the key point to make is that unlike previous studies where we'd actually seen maybe increased mortality, now we're shifting to this side where you are achieving better glucose control, having lower weight, and improving cardiovascular outcomes. Moreover, we also are now able to show this group of drugs improves kidney outcomes. What are they? Well, they are preventing people from dropping an eGFR below 50, going on to end-stage renal failure with dialysis, and actually dying from kidney disease. And that was actually around 20%. So that's 2019. But now, in the last 2 months, we have breaking news from the GLP-1 therapies. And what is that? Well, firstly, we have the SELECT study, which on August the 9th reported in 17,605 non-diabetic patients, overweight with a BMI of 33 and pre-diabetic, 66%. This is completely changing the role of GLP-1s. You know, we had them for diabetes. Now it's pre-diabetes and overweight. They were high risk, so they had myocardial infarction and stroke, and they were given the higher dose of semaglutide, not the 1 milligram dose or the 2 milligram dose, which is now approved by the FDA for diabetes, but 2.4 milligrams. And the study was positive in that it showed a 3-point MACE reduction of 20%. Next, we have the STEP HFpEF study. This is, again, non-diabetic individuals who are obese, BMI of 37, who have heart failure with preserved ejection fraction. Their average median left ventricular ejection fraction was 57%. But I must say, if you look at the paper, some of them, actually a proportion, about 20%, did have lower ejection fractions up to about 40%. But giving semaglutide 2.4 milligrams for 52 weeks, just a year, there was a significant drop in body weight, and there was an improvement in the Kansas City Cardiomyopathy Questionnaire, which is a standard measure of heart failure. More importantly, look at this, the 6-minute walk. It increased from, in the placebo group, it was 1.2 meters, whereas the 6-minute walk was 21.5 minutes. Okay, so there was an improvement in heart failure with preserved ejection fraction. And the last study is the FLOW study, which actually is in type 2 diabetes. It is with semaglutide 1 milligram. And what it shows, and the most important thing about this is that this is literally 6, 7, 8 days old. The study has been stopped early. And it's not been stopped early because we are doing more harm, but actually the adjudication committee do not feel it's ethical to continue on this trial and not give the placebo arm the same treatment because of the benefits. And those benefits are in terms of reducing renal outcomes. So we now truly have, I believe, a paradigm shift from previous therapies. And that paradigm shift comes from not just GLP-1 therapy, which I've talked about, but what we now have are dual agonists and triple agonists, which are literally about to be licensed, approved. What are they? Well, I think we are now in the best of times because we're going to have the dual agonists. You may have heard of Mounjaro, and we're going to have retatrutide, which is the triple agonist. What is a dual agonist? Well, this is combined GLP-1 and GIP receptor agonism. And the triple agonist, or triple G, is GLP, GIP, and glucagon. And you might think, glucagon? But that surely raises glucose. No, it actually, when you stimulate the glucagon receptor, it has amazing effects on liver fat, and it really reduces weight as well. So what's the data with these dual agonists? So the tirzepatide, once weekly for the treatment of obesity, This starts with 5 milligrams, 10 and 15 milligrams is the maximum, okay? Now, if you look at this study, body weight was 100 kilograms, 102 kilograms in these patients. A proportion had pre-diabetes, 40%. Not diabetic, but pre-diabetes. And their glycated hemoglobin, you can see, was 5.6%. First of all, you have to look at the effect on weight. Unlike semaglutide, which is achieving 6, 10 kilograms maybe, we now have weight loss of 20 kilograms in the maximum 15 milligram dose. This is now reaching bariatric surgery territory. And more than 25 kilograms in weight loss, right? Can you imagine a patient who's 100 kilograms going to get down to 75 kilograms is being achieved in almost 40% of people. Furthermore, HbA1c less than 5.7%, which is what I call a cure. Actually, people cheat when they say 6.5% because you've still got pre-diabetes. It really should be less than 5.7%. And that is now, in all these people who had pre-diabetes, 95% were normal. You've cured their diabetes. That's tirzepatide. And then tirzepatide versus semaglutide. You'd expect, actually, in type 2 diabetes now, what you see is weight loss of 11 kilograms. And it's actually known that in diabetes, as opposed to obesity, there may be a lesser effect on weight. But look at the HbA1c reduction. In the maximum 15 milligram tirzepatide dose, 2.3% HbA1c reduction. With a starting HbA1c, not 10 or 12%, but 8%. So you are now shifting into 6% and below. And in fact, HbA1c less than 6.5% is achieved in 80% of people, and less than 5.7%, which really is, I believe, a cure, 46% of people in the highest dose. And does it have cardiovascular improvement? We don't have any big data yet. However, Naveed Sattar has done a meta-analysis, and there is definitely a signal. So, and this is a signal which you see actually within a year where the curves are starting to separate. And so there is some preliminary data to suggest that this is going to have, it's not significant here yet, but there is nevertheless a reduction. And again, coming back to tirzepatide, because of its initial, so this is patients with diabetes against insulin degludec. You'd think insulin is going to be, is going to be easily better. However, what you see here is the effect on weight. You'd expect that. If you put people on insulin, it's no secret that they're going to put on weight. Whereas in the tirzepatide arm, you can see they're going to lose weight around 12 kilograms, okay, on average. But in addition now, what we have, which is why the hepatologist should have been here, we have evidence that these medications really have an impact on liver fat. So there is a reduction of almost 50% in liver fat on even the 10 milligram dose of tirzepatide. And the last big one is the triple G, right? The retatrutide. And this, again, is a lily drug. I mean, you can forget about insulin. I know they've withdrawn out of here, but they've probably done it for a reason. I've been told by my colleagues that it's because they're not making enough money, but I reckon it's because they will come back. They will come back. So this is 338 adults, overweight 108 kilograms, okay, BMI of 37. Their weight loss, if you look carefully, 24 kilograms. Unheard of. That you're going to lose 24 kilograms in an individual who's 108 kilograms. If you go into the appendix, which I did, this was really amazing. 26 out of the 338 adults achieved more than 30% body weight reduction. 30 kilograms. Forget bariatric surgery, right? This is going to replace bariatric surgery. And moreover, the other important message is when they looked at people with a BMI less than 35 and a BMI more than 35, what you actually see is that the people who were more overweight had a greater loss of weight. So I suspect if you have a 140 kilogram person and you give them this drug, you're going to get like 40 kilogram weight loss. So, and on top of that, for the ladies in here, guess what? This is, it likes females, this drug, because actually the females in this study got greater weight loss. And you can see here, they actually lost on average 4 or 5 kilograms more, even though their starting weight is exactly the same. So there's we don't know why, but it seems to have benefit. Something, honestly, when I read this paper, it blew my mind. Semaglutide in early type 1 diabetes. You would never think a GLP-1 agonist should be used in type 1 diabetes. This is a study just being published as a letter in the New England Journal of Medicine. These are people aged 27, recently diagnosed with type 1 diabetes, within 33 days. HbA1c of 11.7. They are on, actually, insulin around about 30 units, but they were given alongside insulin semaglutide, 0.125 to 0.5 milligrams. And what did they find? Well, HbA1c dropped from 11.7 to 6%. But at that time, you can imagine, oh, they're on semaglutide, but they're also on insulin. However, look what happens. Prandial insulin, Novorapid, Actrapid, was eliminated in all patients within 3 months. So they were no longer on prandial insulin. And within 6 months, in 7 patients, even their long-acting insulin was stopped. So at 12 months, these patients were just on semaglutide, type 1, and yet their HbA1c was 5.7%. And when they did CGM in these patients, 89% of the time, they were all within range. Finishing off, is there another indication that we might get for GLP-1 therapies? So the first signal comes from the LEADER study, which is liraglutide, looking at cardiovascular outcomes. And in that study, they actually looked at amputations. And what did they find? Well, they actually showed that if you were in the liraglutide arm, you had a 45% reduced risk of undergoing a major amputation. Simple. If you were on liraglutide, if you were on a GLP-1 receptor agonist, you had less risk of amputation. Now, is this because it was improving blood flow, or was it because it was improving neuropathy? Well, to address this, actually, my favorite subject, which is neuropathy, so I'll show you. So this is something that we've developed over the last 20 years, something called corneal confocal microscopy, to assess neuropathy, right? So what we do is we scan patients' eyes within like 2 minutes, and we can look at nerves, and we can look at the integrity of these nerves, literally. And we can then, I can really look into a patient's eyes and look at their nerves and measure them. So what we've done actually in Qatar is looked at the effects of GLP-1 therapy, exenatide once weekly with pioglitazone at neuropathy. What we first of all did is took patients that had a HbA1c of 10.5%. We randomized them to receive either once weekly exenatide with pioglitazone or basal bolus insulin. Both groups dropped their HbA1c to 7%. However, when we did the scans of their eyes, we were able to show that they had an increase in corneal nerves, in nerve regeneration. So there was regeneration of nerves in these patients. Then, actually, I shouldn't put this up, but Haji comes along. I play football with him. Haji is upset with me because what good am I, Prof, if you go around the world, you talk about how wonderful this therapy is, do something for me. And I said, Haji, I can't do anything. You haven't got diabetes. He said, come on, Prof. So anyway, he managed to get some semaglutide. And he was started from 96 kilograms, and he lost actually 22 kilograms. And because I could, I said, okay, if you're going to take this without my permission, I want you to do CCM. And actually, I was shocked because I saw repair of nerves. So even just being fat without diabetes, he already had less nerves, and these started to repair within 6 months. And then we have, in Qatar, we then have gone on to look at actually overweight kids. So we have a lot of obesity as a major problem amongst the Qataris, right? And we have a cohort actually currently 69, but it's growing now. It's 220 soon. We've got kids who are weighing around 100, 120 kilograms. And when you ask them about neuropathy, they don't have any symptoms. They have normal vibration perception. Nerve conductions are normal. But when I do look at their nerves, what you see is they have less nerves already. And these kids are like 12 years old. What we've now done is actually given them semaglutide. Okay? And this is within license, actually. What we show so far is that they lose weight, but also, you can see here, corneal nerve fiber density increases. So this is actually with, these are kids, 12-year-old. And going beyond that, we now have evidence that these nerves are lower, but particularly the kids who had acanthosis have actually more weight, but also have less nerves. And then the semaglutide, you can see they reduce weight and they repair their nerves. The last bit is all about the brain, GLP-1 beyond glycemia, almost finished. So what you have is data now that GLP-1 therapy could be used for Parkinson's disease and dementia. And there is clinical studies published that show that if you give GLP-1 to people with Parkinson's disease, their motor score improves. And there are outcome studies showing that if you put people on GLP-1 therapy, they are less likely to progress to dementia. And in fact, there is now 2 large phase 3 trials with oral semaglutide, which are ongoing to look at the effects on Alzheimer's. These are large, multinational trials which will report in 2025. And they will look at the effect on dementia. So Muhammad Ali said, the man who views the world at 50, and I'm just over 50, the same as he did at 20 has wasted 30 years of his life. I hope I haven't wasted 30 years of my life, and I hope you don't waste 30 years of your life. Thank you very much.
Thank you so much, Dr. Reyaz Malik. Any questions, please?
Okay, I'm Professor Jamil, chairing medicine at Buckeye Medical University. It's always a pleasure to meet and listen to Reyaz. A comment from my side and feedback, not the feedback, but your comment on that. Practicing as an internist, a lot of patients, cardiometabolic and hepatology and GI. One of the most important things which we have seen for the last very few years is that semaglutide has a very significant role as far as steatotic hepatitis is concerned. And this is one thing which in our part of the world is now leading after Hep B and C. So this is one thing which has been noticed. We are gathering data about it. So very, very positive result as far as our country is concerned, because truncal obesity is very, very common here in this part of the world and in all ethnic groups. So this is the one thing as far as semaglutide is concerned, our own things which are going on. And the other thing is that now the nomenclature as far as the steatotic hepatitis is concerned is changed, and they have taken the word, thank you very much to those people, ethanol from it. Okay, so this is the one thing. And of course, we know that the semaglutide, which the question which I wanted to ask, you already answered that, okay, that its affection on cerebrum. So anything else you would like to add to this?
I think, it speaks for itself, the data. Of course, there are lots of people now talking about side effects, gastroparesis, but really the data is not there yet. I have seen no data at all. And the important thing you have to note is that the first of these GLP-1 therapies was 2004. It's 20 years since we've had these drugs. And really, we haven't seen any major signal. So honestly, I think it's a positive, and this is just the beginning. Semaglutide is the beginning. The rest of the drugs that are coming, I can tell you, I've spoken to people in, head of companies, and they're like, forget, semaglutide. The next ones are really going to change, game changers. Yeah.
Thanks.
Thank you, Reyaz. It's always wonderful to listen to what you have to say, and you present the data in such a more clinical way that probably it's very hard to, you can all relate to what you're saying. I have a quick question regarding, and I'll quote you one example and then I ask my question, is SGLT2. We know that the more you dissect it, probably there's less of racial data based on, like there's less data on African American as compared to Caucasian. And when we compare the less data on African American or the Asian, it doesn't reflect the same strength of data in African American. If I'm not wrong, SGLT2 has a major effect on the heart failure in African American, but rest of the benefits are not clearly seen in African Americans in SGLT2 as robust as you see in Caucasian. So in your experience, do you think, is that something that, number one, unfortunately, where you're presenting or where you're speaking to us, in this part of the world, we don't have that much data on the Pakistani population on the use of GLP-1. There's some data on Indian subcontinent, but still it's not as robust or as detailed as you would see in the Caucasian world. And even if studies that you see, some of them are not even keeping this subcontinent. So do you have any thought or any doubt that could there be a disproportionate effect of GLP-1 in different ethnic background, or do you think it's just across the board and it's probably not related to any ethnic background that you will be?
So first of all, I would say Novo Nordisk need to put money into this country, into this region, and look at data from here. All right?
Thank you.
That's number one. Now, there is definitely, with the GLP-1 therapies, there is definitely, and particularly with the triple G, there is a big effect on visceral adiposity. And that's where I think we have always suffered, that we've had therapies that haven't really affected, and this is where Asians are affected. So I can only, I can't honestly say that, because the studies that were done were all predominantly Caucasian. And you're right, the SGLT2 story is there. There is, again, small proportions of, and that was true for the blood pressure lowering treatments as well. We just need to do more studies here.
Thank you.
Yeah.
Excellent.
Thank you.
Thank you, Reyaz. As always, an excellent talk. Just a query that someone who is losing the weight through the semaglutide, that has got a beneficial effect on the cardiovascular, the fat, and all these effects. What about those people who are losing weight without the semaglutide? Do they have the same beneficial effects on the cardiovascular as well as the liver fat?
Other ways of losing weight?
Yeah, like diet and exercise.
The data isn't there. I mean, you look at the studies that have been done for bariatric surgery, yes, where there have been large amounts of weight loss. We know there are good cardiovascular outcomes. There are good renal outcomes. There are good mortality outcomes. Really, we've not had, like the Look Ahead study, showed that you could lose some weight, it regained, and really there was no major cardiovascular benefit that was seen. I think it's all about how much weight loss you get. And honestly, I don't know if there is a magic number, but I think minimum is 15 kilograms. If you can lose more than 15 kilograms, you're going to start to see benefits in terms of diabetes outcomes and cardiovascular outcomes.
Okay. In the interest of time, a last question for Professor Jamal Raza, and then we have to finish.
Thank you, Reyaz. Fantastic presentation. I was very excited to see the type 1, newly diagnosed type 1 data as I deal with the pediatric age group. What is the lowest that it has been used, and what do you foresee? Do you foresee it going down? I mean, even if it is recommendation is not there right now for the use in the pediatric age group. Do you foresee that it might happen in the coming years?
Yes, so there will be an approval. So liraglutide, so for type 2 diabetes and obesity, we now know that liraglutide has a license. Semaglutide will happen as well, I'm sure. And all of the agents, because obesity is a bit, but for type 1 diabetes, this is actually just the first set of studies that have been done from Paresh Dandona. And we now need a randomized study to actually see the benefits of this to be used alongside, what we have in terms of insulin. I mean, if you look at it, there's the immunotherapy, and that's going to cost like $300,000 to delay type 1 diabetes. And this is going to cost you nothing hardly to delay type 1 diabetes.
In practice, we do see a lot of these honeymoon phenomena.
Yes.
Where they produce their endogenous insulin and they are sometimes off insulin. So if we can support that with the use of this drug, that would be fantastic. And
actually, if you look at the New England Journal of Medicine paper, they compared it to 3 other trials where they looked at the honeymoon phase. And if you look at the curves, those curves start to come up after the honeymoon phase. This one stays flat on the semaglutide. So there's something special going on. I don't know what it is. Yeah.
Okay. I think thank you very much in the interest of time. And just to answer Professor Jamar Raza, I have used it up to age 13, the GLP-1 agonist, weekly one, duraglutide with really good effect. We're actually in the process of submitting as a case series report in adolescents with type 2 diabetes. So even duraglutide resistance now to be used in type 2 diabetes in adolescents.
Dr. Reyaz, I've got a very brief question. You mentioned that semaglutide, it reduces liver fat as well. Now, since it is a very simple tool, do you recommend that assessment of the semaglutide can be assessed by the routine liver fat evaluation?
Yeah. Well, the data I showed you was with CT-based liver fat assessment, but actually, you can use ALT, AFT, FIB4. There are data that show that there is an improvement in those numbers as well.
Okay, thank you.
Yeah.
Thank you so much. And now I will request Professor Najmul Islam and Dr. Umar to present a token of appreciation to Dr. Reyaz Malik. Thank you so much. So once again, I would like to thank our chairpersons and our speaker.